my name is Mark Gerber. I'm a neurosurgeon in Naples, Florida. I've actually been in practice a little over 25 years now in Naples. I've been a general neurosurgeon doing brain and spine the entire time. I do a little bit of peripheral nerve and some spinal cord stimulation for pain, but a lot of spine. Probably about 85% of the practice has been spine. I was a very early adopter for motion preservation, starting with some of the cervical artificial discs, mainly because a lot of the fusions that we do, you'll see breakdown of the next level fairly quickly and people going back to the OR for additional surgeries. So I've been putting in artificial cervical discs and lumbar discs since 2006, and so I have a fairly extensive experience with motion preservation. One of the problems is a lot of people will come in and say they want an artificial disc and not a fusion. And part of what you'll see is that as we all age and gravity pulls us down and we get shorter, a lot of the disc spaces in the neck and lower back will collapse. And once they start doing that, you start forming some bone spurs, which really don't allow for motion anymore. So a lot of the fusions that we do are really taking down of bone spurs and making more room for the nerves. And the fusion in and of itself is not an issue if the bones are already not moving. For a lot of people, if there is normal motion at that level and good preservation of disc space and just worn down joints, the TOPS is a great device. I was very excited when I first saw it. I was actually part of the FDA trials in the United States just because this is the first motion preservation device in the lumbar spine that I've been excited about. There have been some others and they all have gone by the wayside. But this one does have a very good track record. The bench testing for it has been very good. I have put in, I think, around 35 of them now um, over the last, I think, 3 years that I've been doing it. Um, Knock on wood, I have not had to take anyone back to the operating room. Have not had a failure of any of the devices. Um, some of them, we've done extensions. They have an extension kit. So if there's one mobile level adjacent to a level that has already started auto-fusing, but you need to decompress the nerves at that level, you can attach a fusion device to the tops, and then you have a fusion at the bottom part where there was no motion, but you can decompress the next level that was already starting to go bad next to the auto fusion and put the tops in. And that has seemed to work very well. Done several of those. But overall, the surgery itself is very similar to a lumbar fusion in that you still have to do the exposure. It's still a real surgery. It's not a minimally invasive microsurgery because you need to take off the bad joints and make room for the nerves. You put in screws. So each TOPS device has 4 screws that go in very similar to a fusion screw system. But the TOPS device goes into the top of those screws and does maintain motion. It allows for flexion, extension, rotation, and angulation. So really it preserves or returns normal motion. Um, the ideal candidates are people who do have a normal height to the disc space, ideally with good hydration, but that's not always necessary. The FDA study did look at what's called a spondylolisthesis. It's just a big word that means that one bone is starting to slip forward in front of the other. The most common cause for that is, I like to say, just like you have 2 knees and 2 hips, every level in your spine has 2 joints. And as those joints start wearing out, you lose some of the ability to maintain the alignment in the spine. And so as the joints really wear down, sometimes to make room for the nerves and take the pressure off of them, you actually have to take the joints off. And prior to the TOPS device, the only option was a fusion. Now that we can put in the TOPS, you can take those bad joints completely off, and you're basically doing a joint replacement for the lumbar spine. And this can be done anywhere from L2 down to L5. The extension devices that I've done have been L4-5 TOPS with an L5-S1 fusion. But I've also done a couple where somebody has had, say, an L4, L5, S1 fusion previously that is solid, and then you take the screws out and you can do a TOPS above the old fusion, and that seems to work just fine also. Um, Indications for it, people tend to do better if they have more leg pain than back pain. Although, if you only have a single level of disease in your lower back with just back pain, with bad joints at that level, people do extremely well. Um, Everyone always asks about stenosis. Even coming into the office, it's like the key word in our world. I actually wish they would get rid of it because I think stenosis is very general. It just means narrowing. The reason people start having problems like radiculopathy or neurogenic claudication is from the spinal canal getting narrowed and putting pressure on the nerves. Um, so any decompression is for stenosis. It's just that stenosis is not specific. And that's why you really got to look at the MRI and say, okay, is this the spinal canal or is it pressure on the nerve roots in the foramen or holes between the bones? Um, how's that first start, Jeff?
It's a great start. That's a great start.
Um, as far as adopting it into the practice, um, my other partners, and I have 5 neurosurgeons in the group, they have all started becoming interested in it and identifying people who are candidates. I really think it's a fantastic opportunity to preserve motion and not have to take people back to the operating room 5 and 8 years later, and in some cases, even a year or two later after a lumbar fusion when the next level goes bad. Gravity is going to keep pulling everybody down, and it doesn't completely prevent adjacent level degeneration, but it certainly takes a lot of the force off the next level. And in the last 3 years, again, I haven't taken anybody back to the operating room for an adjacent level or the next level in their spine. I'm seeing questions popping up.
Yeah, you want to go ahead and just go into questions here?
Yeah, sure. Yeah, it might be easier.
Yeah. So we have a combo question from um, same person. So I have a stenosis at L2, L3, and I have a spondy at L4, L5. Am I a candidate for TOPS?
So yes, and actually at both levels, although more likely than not, the central stenosis at L2-3 usually doesn't require instrumentation. And a lot of times that can be a fairly small opening just to make some room for the spinal canal. And I have done TOPS for a 4-5 listhesis, or spondylolisthesis, and at the same time dropped in at another level to do a decompression. Um, I've never done 2 separate TOPS at different levels, but yes, that's conceivable. I'm not sure if that would get approved by insurance, but again, I've never seen a situation where that would be necessary.
Okay, good answer. Here's another question. I have facet joints hypertrophy and foramen narrowing at L4, L5 and L5S1. Am I a candidate for TOPS?
So yes, and again, as long as there's some preservation of the disc at L4-5 and some preserved motion already, the TOPS is not made to remobilize a level that has already degenerated past the point of motion. But this is a great example of where if L4-5 is currently moving and the facet joints are the problem and have gotten very big and are pressing on the nerves, you can take those joints off at L4-5, put a TOPS in, take the joints or any amount of bone off you need to at L5S1 and do the extension system and do an L5S1 fusion that is attached to the TOPS. And the surgery itself only is a little bit longer and it's not much more of an opening to do that.
Got it. Here's a little bit of a longer question. I'll try to I'll try to make it a little bit brief if I can. So I've had a full lumbar laminectomy 4 years ago, which alleviated the nerve neuropathy However, I've got some severe decompression claudication at L3, L4, and I've been recommended for a fusion. I don't want to do that for obvious reasons, and I've opted for PT, strengthening activity, stretching, and light traction. Um, and as a side note, I have an MRI that's less than 4 months old, but I'm not sure that I qualify.
So that's a tough one. Several different parts. Yes, just having had a laminectomy or a foraminotomy or something small does not preclude you getting a TOPS. So it's more dependent on how much mobility is still there. You can, even with the laminectomy, you still have the joints on both sides at L2-3, L3-4, L4-5, every level. A laminectomy just takes the bone off in the center to open up the center of the canal. So if there's still joint problems or pressure on the nerves, yes, you can take those joints off and you can still put in a TOPS. It really depends on the motion at those levels. And sometimes after laminectomies, you do need to get flexion and extension x-rays or even a CT scan to look and see if the joints have already fused together and what the motion is at those levels. But short answer, yes, you've had a laminectomy, TOPS is still an option.
Very good. What about what have you seen about recovery time from TOPS, and maybe the addition recovery time from TOPS versus a single level TLIF?
So, as I said before, it's a very similar operation for the amount of exposure, and it's still putting in the screws. Most of the TOPS patients go home the day after surgery. I know there are a fair number of people across the country that are doing TOPS at surgery centers or outpatient and using injectables like Exparel, which is a long-lasting anesthetic you can put in the tissues. It's not as readily available for inpatient stays because it's not reimbursed as well for hospitals as it is for surgery centers. But that being said, even without that medication and putting in plenty of local anesthetic, most people do seem to go home the next day. Because you don't have to wear a brace with it, people are not as limited. Um, and usually we see people back at a week, 6 weeks, and 3 months after any surgery like this. Um, I do think that the TOPS patients come back at week one way better than the fusion ones. And some of that probably has to do with inflammatory reactions that you're having and the bony work that's done in the disc spaces to put implants and bone graft into the disc spaces. I think that's more painful anytime you're disrupting the bones and the end plates, which are where the disc was attaching to the bone. But definitely at 6 weeks, the TOPS are much better than the fusion patients. Um, Both sides do well from a neurologic standpoint, meaning if you have radiculopathy or pain shooting down the legs, I think they do very similarly up front. Um, a lot of the fusions that are done, people do not take off as much bone as you would with the TOPS device. So I think in general, you get a much better decompression for all TOPS versus a majority of the fusions. So I do think that there's an advantage to it, just from a decompression standpoint.
Yep. I think we know the answer to this one. So I have an L4-5 spondylolisthesis with a mild scoliosis. Am I a candidate?
Yeah, the scoliosis for just a mild one is extremely common. It's more rare in people over 30s and 40s not to have a little bit of degenerative scoliosis just from things settling down. As long as the remainder of the levels look reasonable and it's not a big angulation, um, and there's normal motion, yes, a TOPS is perfectly fine with a mild scoliosis. Even if there's a rotational component, they've done just fine.
Yeah. Here's a question about a comment you made earlier regarding um, you cannot have more than one TOPS inserted in the spine currently, or at least not adjacent to another TOPS. You want to speak to that again and clarify how we think about single level and
Sure.
how we don't really do two levels
So,
for
and
tops.
there's two parts to that. I don't think that anyone's going to get their insurance companies to approve putting two of these implants in at different levels currently. Although I do think that there's room if you had L2-3 disease and L4-5 disease, it would be conceivable that you could do it or come back at a later date and do a second one. There's no way to currently attach two devices. So if you have adjacent levels, meaning L3-4 and L4-5, we currently don't have the capacity to put a TOPS device attached to a TOPS device. We can do a TOPS device attached to the fusion, like I mentioned. But in general, the best candidates for this have single level disease and only need one level addressed. I do think that at some point, I know there's been some talk about research on adjacent level TOPS devices. I just don't know much about it.
Yeah. Um, Here's another question. Is TOPS only for lumbar, or can it be used for cervical? You know the answer to
So,
that.
yeah, it's a lumbar system. It's the facet joints in the neck are very different. The anatomy is very different. The implants are actually too big to put in the neck, and as are the screws. Um, if there's normal facet motion in the neck, an artificial cervical disc, which is going in through the front end of the neck, works extremely well. And there's really not a good need for the industry to come up with a mobile implant that would go in the back of the neck.
I'm going to combine a couple of questions here, and I think it's around one. One says, "Is it safe to consider a surgeon who has only performed TOPS one time?" I'll just ask that question, and then there's a follow.
So obviously, I'm gonna be biased, and I've done a ton of them, and I'd love to do as many as I can. But to be honest, one TOPS implant is no different for somebody who's done 1,000 single level lumbar fusions. It's the exact same surgery. Even myself, when I did my first one, it's no different than a decompression I've done over and over again over the years. It's putting screws in the same way we put screws in. It's a different implant that sits into the top of those screws. So technically, I have no problem with the surgeon that does lumbar fusions doing a TOPS, even their first time. It's not a big learning curve. And with the training, you do put in TOPS devices on cadavers. So it's not like it's truly the first one that they've ever touched. Yeah, so I don't have a problem with once or twice having put one in, letting them do it. Because,
And oh, I'm sorry. And you might want to expound upon that, because I think the follow-up question, it really follows that line of thinking. It's, what's the training process for a surgeon? Does Premia Spine provide clinical expertise to support the surgeries? That type of question.
sure. So they've actually done a really good job. I did my training up in Indianapolis originally. There was a big cadaver lab up there. I have been um, I hate to call it a professor, but I was a surgeon that was helping out in Miami with one of the cadaver courses. But they do bring everybody in to get trained on them. Um, if some surgeons are not capable of going to one of the cadaver courses, which is the preferred method, it's perfectly fine to do it on what's called a sawbones, which are the fake spines. And again, for a surgeon who's been out in practice for years and has had done so many lumbar fusions, um, it's not that big of a technical change to put this in versus doing the fusion. And then as far as support, um, they're very good, both from, and I don't know a whole lot about the finances and everything else, but if the insurance companies are not approving something, they've been very good at helping my staff get it approved. Um, and then in the OR, there's always a rep from the company present. They have every size imaginable that so there's a sizing device you use to put this in. Once the screws are in place, part of the surgical technique is trials that figure out the angle of the implants and the size of them. The reps are well versed in that, and they're very good at helping you align things and make sure the x-rays, excuse me, look perfect so that you put in the correct size. But yes, there's constant feedback. The company's very good. They like to look at all the x-rays after we're done and give the surgeons feedback, which I actually like. Um, So I think overall it's a very conscientious company. It's not like every other spine company where they're just showing up selling metal. I think they really do care that these are done nicely and people have good outcomes.
On behalf of the company, just an additional comment. I mean, we only hire people with years of experience of clinical support expertise in spine. And then we run them through a rigorous training program, testing. Um, and as you know, Dr. Gerber, I mean, everyone that we have with the organization um, have supported procedures in the OR for years, specifically spine procedures. So very well versed. Um, some actually come out from the clinical world and came into the business world. Um, and so we take that part of our role very serious, very serious.
And I can add to that, even my rep locally, who I've worked with for years and knew spine inside and out, he's been doing it since I was a kid. His first several, Premia brought in a seasoned tops insert rep to the OR. So we had both reps there for the first several, even though he knew everything.
Yeah, it's a really good question that was asked. Um, Here's a question, just a point of clarification from an attendee. So if my issue is L4, L5, is that considered single level or multiple level?
Yeah, very good question.
Yeah,
Yeah, we forget that. We don't clarify things well enough
right.
because that's our lingo. But yes, so a single level is per the disc. So the disc nomenclature would be the L45 disc. So it's the L45 level. So yes, if you have L45, that's one level.
Well, we got a lot of questions here. This is great. Here's another one. I have degenerative changes in the lumbar spine, including spondylolisthesis and severe degenerative disc disease, with mild to moderate narrowing of the central spinal canal at several levels. So this is L2, L3, L3, L4, L4, L5, L5, S1, with the most significant narrowing at L4, L5. Would I be a candidate?
So this gets back to you have to look at the pictures. So one of my biggest pet peeves in my life are radiology reports. And my father's a radiologist, or what was, and we've had this discussion many times, but you can't go off the radiology report to know exactly what the anatomy is. So that's something where you'd really have to look at the MRI and see, okay, some people's severe degenerative changes, I look at the MRI and say, I don't see anything. Yes, we all get degenerative changes. I mean, I'm in my mid 50s, I have degenerative changes. Everyone does. But is that bad enough that it excludes you from a mobile implant? You just don't know off the reports, and you have to look at the pictures. If there's truly severe disease where there's no discs left at any of those levels, no, TOPS is not appropriate. Um, but again, I'd have to look at the pictures.
Here's another question. If the disc is almost gone, I'm assuming from, well, I mean, it could be an injury, but maybe from DDD. Um, does a TOPS open the gap and relieve the disc?
Good question also. This is, and I said it earlier, but I'll reiterate it. This is not a device to return you to normal function. So there has to be motion at that level in order for the TOPS to work. If you're bone on bone, even with a spondylolisthesis, putting the TOPS in, it's going to sit there just like a fusion device would, and it's not going to move because those bones already are not moving.
Um, Here's another great question. So this is related to post-op. Does TOPS prevent a person from playing some sports like golf or motorcycle riding?
It's actually better to have a TOPS if you want to be active than it is to have a fusion. I tell people all the time, you can have a lumbar fusion and go play golf, and you have to live your life. You can't stop doing things, but you're going to have adjacent level degeneration. And if people have a multi-level fusion, they have even higher risk of adjacent level disease because of the amount of stress from that lever arm of fusion. But a TOPS device doesn't put stress on the next level. And yes, by all means, if you have a single level TOPS and you want to play golf or any other activity, I'm perfectly fine with it. Nothing will prevent you from having degenerative changes in general over your life. But the TOPS device, the screws actually bind to the bone extremely well. There's actually no reported cases of the screws loosening or backing out, and there's no hardware concerns from that standpoint. So yes, I think you can do whatever you feel up to.
We do have several questions here relative to um, Dr. Gerber, how they can get in touch with you. So I decided to put this slide up.
Okay.
Um, so they can, so everyone that's attending here, if you would want to take your phones, this would be the easiest way to do it. We have found you take your phone and take a picture of the screen. You'll see contact information um, for um, for Dr. Gerber's office,
And your
and
cursor's over the phone number.
yeah, and the oh, it is.
Yes, there
It
you
isn't
go.
on it isn't on my end, so I can't see it. I'm sorry. Um, and phone number and a unique email. I like that email to contact Dr. Gerber. And if you want to contact Premia, if you happen to be in another part, there's a question here looking for a surgeon in Charleston, South Carolina. If you're in another part of the country um, and you're not accessible to Dr. Gerber, just contact Premia. Contact Shelbin George, and there's Shelbin's information. We can point you in the right direction. Also, if you look at our website, you will see that we have what's called a surgeon locator on our website. It's a map, and that map includes little red dots across the country. And if you click on those red dots, that'll represent a surgeon in a particular geography that is trained on TOPS. And so, but if you'll contact Shelbin, Shelbin can point you in the right direction to talk to a surgeon in your particular area.
And just for full transparency, the number that's up, we just had set up this afternoon for my office for TOPS specifically. I don't think that there's a voicemail on there that says, "Hi, this is the TOPS line" yet. It should be up tomorrow. So if you call tonight, you can still leave a message. I know it works, but the email definitely works already.
Very good. How about one last question? We have 1 minute left, and here's one last question. Does TOPS procedure relieve the pain of sciatica in the glutes and down the leg?
Yes, again, if it's from pressure on the nerve at a single level, and you need to have the joints taken off or just pressure off the nerves and you still have mobility, yes, TOPS is an option for that. Um, the whole goal of all spinal surgery is to take the pressure off the nerves. We always say the surgery is done before the fusion or the implant goes in because our goal is to get the pressure off the nerve so that you don't have sciatica, you don't have claudication. In my world, the implants are an afterthought after you've completed the operation to get rid of the symptoms. It's just that this is a great tool to preserve motion instead of doing a fusion after you've taken the pressure off the nerves.
Well, great. Well, Dr. Gerber, thank you for your time this evening. This has been great. You did a great job answering the
Oh, thank you.
questions and love your style. You did a really good job. Very easy to understand. Once again, everyone on the webinar, if you hopefully had an opportunity to get Dr. Gerber's information or the information from Premia, you will be receiving follow-up information from Premia about getting in touch with us if you want more information about TOPS. So once again, thank you for taking control of your care and being interested in learning more about options for your care or care for your loved ones. This is what this is all about. So thank you for your attendance. Dr. Gerber, once again, thank you for your time tonight. Everyone have a great evening. Take
Oh,
care.
thank you guys. Thank everyone.
Bye-bye.
Bye bye.